And we move on to the next presentation, to chair which I would like to invite another of my young faculty colleagues, Dr. Vinay Mahala, who got his training in GI surgery from KEM. And after that, he's been with us as an associate professor of surgical gastroenterology, is a active member of our transplant team, along with Anand and Shaswat, which is now being led by Dr. Namish Mehta, who has joined us from the Sir Gangaram Hospital. And Vinay will be chairing this session. And the speaker is Dr. GSB Kishore, who's currently a senior consultant GI surgeon at Fortis in Bangalore. Kishore, please come in. Over to you, Vinay.
Good evening, sir. Now, I would like to invite our next speaker, Dr. Kishore, GSB. Dr. Kishore is a senior consultant and clinical head, HPB Surgery and Liver Transplantation Program, Fortis, Bangalore. Sir has a vast experience of more than 20 years in the field of HPB surgery and liver transplant. And sir is an ex-alumni of PGI Chandigarh. So I would not take too much time to introduce sir, as Dr. Kapoor has already introduced him. So sir, now the session is to you to start your slides, sir. Dr. Kishore, sir.
Good evening, everybody. Am I audible and the screen is visible also?
Yes, please.
Thank you, Professor Kapoor, sir, and Sadiq, sir, for this opportunity. The talk is on timing of cholecystectomy in three specific situations: acute cholecystitis, biliary pancreatitis, and post-endoscopic retrograde cholangiography. So, why is timing important in surgery? So, operating too early, the risk-benefit ratio may not be in favor of surgery. This we see in asymptomatic gallstones, where we don't want to operate and take the risk of surgery. Or it may not be technically sound because of the natural history of disease, like in the first week of severe acute pancreatitis, where we don't operate for gallstones. Operating too late also has its problems. And the disease process may cause complications, like a gallbladder stone can slip into the bile duct, cause pancreatitis. And therefore, it is actually important to find when is the right time to operate. Now, finding the right time is not always ideal, because patients don't present in the right time, nor do diseases come at the right time. But the right time would be when intraoperative difficulty can be minimized, and when morbidity can be reduced as much as possible. Now, when we think of intraoperative difficulty, it depends on a lot of things. It depends on the nature and stage of the disease. You can imagine this with respect to gallstones, but it applies to everything. It depends on the condition of the patient. It depends on the operating setup and the equipment and the team support that we have. And of course, surgical expertise is also important. Therefore, it is obviously a relative term when we talk about intraoperative difficulty. When we talk about morbidity in gallbladder surgery, and specifically with relation to timing, we have to look at the risks of waiting with gallstones versus the risk of surgery. Risk of waiting would be biliopancreatic problems, that is having biliary colics or cholangitis or pancreatitis. And the risks of surgery in an acute setting or in difficult situations would obviously be bile duct injury, conversions, and other surgery-related morbidity. Now, all this has to be balanced with patient safety, the duration of hospital stay, and costs. So this is how we picture ourselves when we make a decision about timing a cholecystectomy. And these are the metrics that are used in all journals and all publications to decide when they talk about timing of cholecystectomy. So that's why I've put up this. And in the next few slides, we'll look at some evidence for each of these three scenarios and see how we can make decisions as to the timing of surgery in these situations. So acute cholecystitis first. So if you look at large registry data spanning over many years, most of the time it has been found that lap cholecystectomy done within 48 hours of onset actually results in good outcomes. this is a busy slide, but this is a systematic review of RCTs which have been published on surgery in acute cholecystitis. Acute early surgery is defined as surgery within 7 days of onset of symptoms in almost all of these. And delayed cholecystectomy is defined as after 6 weeks in most of them. Now, the results were that early cholecystectomy results in lesser costs, lesser hospital stay, lesser wound problems, without increase in biliary injury or in morbidity. And there was no difference when patients were operated within 72 hours or up to 7 days. This is a recent meta-analysis. It is a network meta-analysis whereby it takes into account the different durations that were taken, like 24 hours, 48 hours, 72 hours for early, and delayed like 7 to 5 weeks and 6 to 12 weeks. So the message from this paper was operating within 72 hours actually results in the best outcomes in terms of conversion, in terms of hospital stay, and there was no difference in bile leaks or postoperative complications. It is a well-established fact that operating within 24 hours or 72 hours, there's no difference in outcome. And while operating between 72 hours and 7 days, that is between 3 and 7 days, we should remember that we will anticipate a difficult cholecystectomy. By definition itself, this becomes grade 2 Tokyo, more than 72 hours. Still, lap cholecystectomy is the best option. We have to expect a difficult cholecystectomy, and bailout procedures like subtotal cholecystectomy may be required in this instance. And it is always better to do this in an experienced setup. So you should evaluate your own surgical skills and the setup you're in before you take on such a patient for a lap cholecystectomy. There is recent data which says that operating even beyond 7 days in acute cholecystitis actually results in similar outcomes when compared to patients operated less than 7 days in terms of biliary injury, bile leaks, and hospital stays. This is, of course, a retrospective study, but we should remember that when we interpret data, we should look at it carefully. If you look at center experience when operating more than 7 days after onset of symptoms, this particular multi-center study, although it was a retrospective analysis, they defined high volume centers as more than 35 cases of acute lap cholecystectomies for acute cholecystitis per year, and low volume centers as less than 35. It was found that the duration of surgery, bleeding, other complications, bile leaks, they didn't specifically mention bile duct injuries, but bile leaks, all were obviously better in the high volume centers. An interesting finding of this study was the morbidity was not different when people were operated in high volume centers before 7 days or even after 7 days. So the message is you can take on cases after 7 days of onset, but it has to be a high volume center and performed by an experienced surgeon. Obviously, the risks of waiting are biliary problems, like we discussed. This gives a number to all those problems. The probability of gallstone-related events can be as high as 30% at 1 year, and pancreatitis about 6 to 9%. So it is a significant morbidity by waiting on a patient with acute cholecystitis. So early surgery, when safely performed, is good. So grade 1 Tokyo, lap cholecystectomy, especially if the timing is less than 72 hours. There's no confusion here. 72 hours to 7 days, we have to anticipate a difficult cholecystectomy, and it has to be done at an experienced center. More than 7 days, you have to be very, very choosy, not for everyone to do. And patients on blood thinners is a separate topic, but these also generally you should temporize. And grade 3 acute cholecystitis with organ failure and patients who are too sick, it is always good to defer the surgery and optimize them before going in for a surgery. So in summary, it is very clear that from evidence, we all know this as a matter of fact, but I'm just discussing the evidence. Within 72 hours of onset, lap cholecystectomy is always a good choice. And this really works because delaying the cholecystectomy causes delayed biliary problems, and it also increases overall hospital stays and costs for the patient. Now, the second part, we finished acute cholecystitis. The second one is biliary pancreatitis. So there is a good paper. This is from the AIMS group. This is again a systematic review and meta-analysis of all RCTs that are published. So this is a forest plot. If you look at recurrent biliary events, there are two groups here, the early group and the delayed group. So these are the number of RCTs. If you count them, there are 7 here. So 7 RCTs. This diamond is the effect size. It clearly favors early cholecystectomy. Why? Because if you look at biliary events, the biliary events were only 9 out of 428 patients. That's 2% in people operated early, whereas the biliary events were 133 out of 439. That's about 13% in people who had a delayed cholecystectomy. So clearly, operating early for biliary pancreatitis results in lesser biliary events. Similarly, recurrent pancreatitis, the effect size is very, very clear. It is for early cholecystectomy. Early, when I say it's less than a week and preferably less than 3 days. Again, pancreatitis 1.3% in people who had a cholecystectomy early, whereas 7.6% in people who had a delayed cholecystectomy. Instances of acute cholecystitis were 3% in the delayed group, 0 in the early group, and need for ERCP also was lower in the early group. Surgical complications were not different. So what this essentially says is it's quite a conclusive sort of evidence with multiple RCTs which have no bias. And so it is very safe to say that same admission cholecystectomy has a clear advantage in mild gallstone pancreatitis, and delaying surgery results in biliary colic, significant readmissions, and pancreatitis, which sometimes can become life-threatening. So that's about mild pancreatitis. In moderately severe and severe acute pancreatitis, there is not much hard data. There are no RCTs. It is a common sense approach. If the pancreatitis is severe, patient is an organ failure, patient is in ICU, we wouldn't want to do a cholecystectomy. And management of the pancreatitis takes precedence. At some stage, if the patient is operated, especially by minimally invasive approaches for pancreatitis, if the local conditions are not hostile, and if the surgeon is confident about a safe cholecystectomy, it can be done. Otherwise, generally in these situations, it is usually done after 3 to 6 months. Now, the third part of the talk, after ERCP. Now, after endoscopic sphincterotomy or ERCP, this is again a RCT which compared early cholecystectomy and delayed cholecystectomy after 6 to 8 weeks. Again, the same metric, recurrent biliary events and complications related to that are much higher if patients are offered cholecystectomy in a delayed fashion. So even in population-based studies, it is quite clear that having a cholecystectomy early reduces the risk of having adverse biliary events by as much as 90%. So British guidelines, Dutch guidelines, they say that it should be done within 2 to 3 weeks. And the costs in this depends upon the setup, the insurance, and so many other things. There is also, since we're talking about timing and ERCP, there is also this intraoperative ERCP which can be done. And the pros are it causes lower risk of pancreatitis because we cannulate the cystic duct and give the endoscopist a wire through the papilla. So the chances of entering the pancreatic duct are almost negligent. And it's a single anesthesia in patients who have comorbidities. But the cons also are significant because if you really try to do it, the logistics are not easy to arrange, the timings, the equipment, everything has to match. And it needs a very close cooperation between the surgeons and the gastroenterologists, and they should have good understanding, both should have good understanding of how it works. Otherwise, it will lead to a lot of problems. And if you don't time the cholecystectomy well, they insufflate, and if there's a lot of the bowels get distended, it's difficult to perform the cholecystectomy. So the sequence and everything should be sorted out beforehand, and it should work well. In specific patients, it really works well. but most centers have not adopted it as a routine. And
Sure,
if
another
you look
2-3
at
minutes, please.
Yes. If it looks at, thank you. If it looks at evidence, if we look at evidence, again, this is, it says that there's no difference in the CBD clearance rate or complications, but there's a lower instance of pancreatitis and cannulation failure. So most of the time in practice, what is done is we wait for about 24 hours after the ERC, look for complications, and then do the surgery. Now, the rationale of that is sometimes ERC causes complications which can become life-threatening, like pancreatitis, which occurs in about 6-7%, bleeding in about 2%. So if this occurs, it will be a confounder after surgery, and we are wondering what happened, and the delayed recovery is there. So it's difficult to explain to patients. So it's always good to wait for 24 hours and then do the surgery. Just a couple of slides on percutaneous cholecystostomy. It is pertinent because of the timing. So there is again retrospective data for this. The evidence seems to suggest that it is better to do it after 2 weeks when the local conditions are a bit settled and blood loss and conversions are less. So at least 2 weeks of waiting is what is recommended. So the final 3 slides, take-home points. In acute cholecystitis, presentation within 72 hours, it's clear-cut. You should offer a lap cholecystectomy. Between 72 hours and 7 days, it depends on center experience and surgeon experience, but it is still good to offer. More than 7 days, please be very choosy about offering surgery. It may be temporized to do this. It may be safer to temporize the surgery. In mild biliary pancreatitis, very strong evidence to do lap cholecystectomy in the same admission. Moderate to severe, it's a common sense approach. Pancreatitis management takes precedence. After ERC and stone clearance, after 24 hours, but preferably within 72 hours. And post cholecystostomy, I've just put a figure of around 3 weeks, but it has to be individualized based on patient condition. Thank you very much.
Vinay.
Yes, sir. Sir, Dr. Kishore, sir, first of all, I would like to congratulate you for such a well-organized, evidence-based, specifically because you have included all those evidence-based studies for all 3 situations which we, being as a surgeons, are routinely dealing in our day-to-day practice. Because most of the centers, I think, the crux of the surgery in acute cholecystitis setting is the expertise. Expertise is the key. As you have rightly mentioned that if we have a high volume center, then definitely we can proceed with in acute cholecystitis setting even in between 7 to 14 days. But I think one should have to keep bailout procedures in their hand if they are dealing acute cholecystitis in after 7 days. And second topic, as you have rightly mentioned, mild biliary pancreatitis, as the consensus is that we can do the surgery. Like in our practice, we used to say a line that the patient with gallstone should go without a stone immediately within the same sitting of the hospital stay. And I think you have rightly covered the topic post ERC when to do the surgery. So, sir, I think you have covered all those 3 situations.
Take the comments and questions from the chat box, Vinay.
Yes. So, first of all, we have coming from Dr. Shalu Gupta, ma'am. In moderate pancreatitis, if CBD stone with jaundice, ERCP when indicated, sir?
Again, that's a nice question, although it's a totally different topic for discussion. ERCP, if the patient has cholangitis, that's a short indication for ERCP. And of course, if the patient has, pancreatitis and local complications already, then I think the pancreatitis management will take precedence. Yeah, it depends on a lot of things. You would obviously image the patient, see the MRCP, see the size of the stones and what is happening. So if it's very small stone, sludge, and if it is nothing, we can just wait it out. But if it is early in the course of pancreatitis and there are significant stones, then you might want to do a ERCP and at least tend the patient. Especially, I think cholecystitis is the only clear-cut indication. Now there's a lot of
Sorry.
Yes, sir.
No, please carry on.
Now, I think now there is a lot of recent evidence also. There's a recent RCT also that has been published on timing of ERCP and in pancreatitis. So, yeah.
Before this, there is a comment by Ajay and a question by Naomi. Please take that.
Sir, I'm not able to see that comment, sir.
Okay, Ajay says, yeah, I'll read it out. Dr. Ajay Sharma says high volume centers have always been discussed, but he thinks it should be corrected as high volume surgeons, as experiences only of the surgeon, especially as far as lab chole is concerned. And secondly, high volume center can have relevance as in case of problem, you can have support. Yeah, that's an important point. Naomi wants to ask if after ERC due to gallstone pancreatitis and CBD stone extraction, you found no stone in the gallbladder, would you still perform cholecystectomy? Kishore.
Yeah, that's an interesting question. I mean, you have to evaluate if the stones, if you think the stones came from the gallbladder in the first place. What I mean is, if you think the stones have slipped from the gallbladder, I would still do a cholecystectomy. If you think there are stones that are primarily formed in the bile duct, like if there's some other pathology in the bile duct, like a stricture or a choledochal cyst which has led to the formation of stones, then you can see how we want to address that primary pathology. But otherwise, if the stones have slipped from the gallbladder, I think a cholecystectomy should be done because it will again form. I mean, once the gallbladder has formed stones, it's likely to form stones again.
Oh, that's what makes sense. Yeah, Vinay, take the question from Kaushik.
Yes, sir. There's a question from Kaushik Bhattacharya. Is there a learning curve for surgeon embarking on laparoscopic cholecystectomy in acute setting? What is the definition of surgical expertise and qualification to be designated as an experienced surgeon before she take on acute cholecystitis cases for lab chole? Kishore?
Yeah, there is definitely a learning curve. So that part of the question is very clear. But in terms of volumes and metrics, I don't think there is any agreed standards, nor are there formal accreditation bodies which can say that you have done so many, so you're experienced to do acute lab choles for acute cholecystitis. So I mean that you have to take an individual decision. If you think it is difficult for you, it's difficult for you. So you shouldn't take it on and not cause a problem. So I don't know if there's an exact number. There are numbers which say, I mean, there are, studies which say that bile duct injuries can occur by experienced surgeons also. So it's not just the numbers. It's just that if you can do it safely, I mean, you should do it. But that decision you have to take. So I don't think there is any formal way to, define this. So I don't know. I can hear from Sadiq sir or Professor Kapoor to see if there's any way to define this.
We have another question from Jayanta Bhaumik. For a documented CBD stone, what is better, pre-op ERCP or a post-op ERCP if CBD surgery expertise is not available?
Practically speaking, a pre-op ERCP would be better because that is conventional and that is what is normally done. The reason for that is, suppose the ERCP fails and you're doing surgery, you always have the option of doing a surgical clearance, with a lab CBD exploration or a open surgery if you can't do it laparoscopically. But if a post-operative ERCP, then if the ERCP fails, then you have to fall back on surgery again and you have to go back in. So only from that point of view, I would think that a pre-op ERCP is sensible.
Yeah, quick answers to some remaining questions, please.
Yes, sir. There is another question from George G. Torres. Do you consider some indication for open in difficult acute cholecystitis conditions?
Again, it depends on the expertise that is available. If you have sufficient expertise and if you can adopt various bailout strategies, which are clear-cut and well-defined. Again, it's a long sort of talk by itself. You can do most of the acute cholecystitis. But intraoperatively, if you find that it is difficult and you cannot proceed, it is always safer to open and do the surgery. So that decision sometimes has to be taken intraoperatively. Most of the time it has to be taken intraoperatively. But this is again a personal sort of thing. It's different for different people. Different surgeons have different levels of experience. So whatever is your experience, the end point should be, it should be clear that you have to remove the gallbladder, save the bile duct, and do a safe surgery. So if you can do it laparoscopically, well and good. If you think it is difficult, it's better to do it open. If you think it's too difficult, you can back out also. So.
We have last question, sir, from Abdullah Mamoon. Patient admitted with recurrent gallstone pancreatitis and patient is settled, but his altered liver functions are there and lipase level are 2600. Can we do the lab chole now or should we wait for the to drop down the lipase?
See, I mean, there is no rationale of doing serial amylase or lipase to monitor the pancreatitis. That's the first thing. And earlier, I think there were some papers actually on this which looked at serial lipases as the serial amylase values before saying that the pancreatitis has settled and going in for surgery. I think that is a sort of outdated concept. This was there in Annals of Surgery. There's a paper actually in Annals of Surgery which looks at falling amylase levels as a criteria for deciding that the pancreatitis has settled before going for lap cholecystectomy. But this was in the late 90s or early 2000s. But I think nowadays we don't really follow that. We don't look at serial values of amylase lipase to see if the pancreatitis has settled. If the patient has settled clinically and the imaging wise also there's no large collections or necrosis, so that would be a good time to do the lap cholecystectomy.
So there is a another question. Should MRCP or ERCP be done in every case of gallstone pancreatitis?
No, the short answer is no.
Okay. I think we have covered all those questions which have been there in the chat box. Kapoor sir.
Okay, thank you, Kishore, thank you, Vinay. And with that, if
Dr. Kapoor, can
yes, Sadiq, please
just make one comment that
yes.
I must always say this, that Kishore has the special art to make literature and evidence more readable and understandable, and that's why I love his presentations all the time. So thank you very much. And I just want to address this point which was raised about experience and how you should do it. I think the first and most important thing is to develop graded expertise. So you start doing in early in grade 1, then progress on to grade 2, and then go along in terms of the timing, in terms of how far you can go to do an acute cholecystectomy. And the experience you can gain if you have a center with people who are doing these things at various points. And in that sense, the center experience is also important because you watch people do it and you gain expertise and understand how to deal with this situation. So a combination of these two things would get you to the level that all kinds of acute cholecystitis you can do. That's from my side. Thank you very much.
So Dr. Jorge Torres is one of the senior HPB surgeons from Brazil. Thank you, Dr. Torres, for joining. I've been putting this small note in the chat box that those who are still not members of Jaipur Surgical Tutorial, please send a WhatsApp message to Dr. Anand Nagar, my colleague who's been coordinating GST activities for last more than 2 years.